I would like also to do an agreement to Gabriel Gijón, that is a very good leader in these cases. And I want to present my work about the effect of anesthesia with or without a vasoconstrictor in mechanical matricectomy. Treatment of an ingrowth nail involves removal of the nail spicule and mechanical or chemical matricectomy. We can perform a mechanical matricectomy like Supan or a Winograd technique, or chemical matricectomy with phenol. Usually, they are performed under block anesthesia.
No está compartiendo o sea, no está viéndose el de esto, ¿no?
Please, Professor Alfonso Martinez-Nova, you can share the whole screen?
I am sharing the whole screen, I think.
But well.
Oh, sorry.
No problem.
Okay.
But we see the small slides.
The small
you know
screen,
I mean?
Okay. Yeah, but I am.
PowerPoint.
No.
Yes, that's it. Thank you.
Yeah, this is good now.
Yeah.
Okay, perfect. Okay. They are usually performed under block anesthesia. Most surgical procedures on tools are performed under anesthesia with no vasoconstrictor and ring digital tourniquet. But this ring digital tourniquet, the time must not exceed 20 minutes. This is good, well known in a paper of Becerro de Bengoa that shows that times over 20 minutes could be dangerous for the pH of the toe. Well, the use of vasoconstrictor has been discouraged in podiatry for a long time due to possible complications like toe necrosis. This fear, this afraid of using vasoconstrictor in podiatry is not supported by the literature, by the studies, because we know that in dermatology, surgeries performed on the fingers, the vasoconstrictor is well known and used in the literature. So why are afraid of using vasoconstrictor? Sometimes this means that one professor, one teacher says to us that it's not possible to use, and we continue to transmitting this message that it's not possible, it's not possible, it's not possible. But Córdoba Fernandez and colleagues report that at concentration of 1 per 100,000 epinephrine is safe when used in patients with no vascular problems. We can use this vasoconstrictor if we need, if the patient has not vascular but not obvious vascular problems. This is well known in this kind of in this paper. Well, although these effects have indeed already been observed in chemical matricectomy with phenol, because the paper of Córdoba Fernandez was performed in the surgical technique of phenol, they remain unknown if in mechanical matricectomies with curettage of the matrix zone, like in Supan technique, like in Winograd technique. We don't know if we perform an anesthesia with vasoconstrictor, what is the effect. So the aim of this study was to compare and contrast the efficacy and postoperative effects in mechanical matricectomies of using an anesthetic with a vasoconstrictor as against an anesthetic without a vasoconstrictor and with a tourniquet. We perform one anesthesia with vasoconstrictor and no ring tourniquet, and in the other hand, a control anesthesia with no vasoconstrictor and ring tourniquet. Well, what was the materials and methods of this study? A short-term longitudinal study was designated. The sample comprised 36 subjects, and the study was approved by the Human Research Committee of the university with ID 5/2018. The inclusion criteria to be involved in this study were ingrown toenail at stage 1 or 2, with no or less than 3 millimeters lateral fold hypertrophy, and with no prophylactic treatment with antibiotics. The exclusion criteria were cervical matricectomies, presence of vascular disease or infection in the lateral fold, because this infection or these issues could affect the results and of latency time of the anesthesia and so on. Well, we have 36 mechanical matricectomies, as we can see in the photo, and at random we divide in 2 groups. One of them, the experimental group, with 18 people, and in these 18 people, an anesthesia of 1.8 milliliters of mepivacaine 2%, plus epinephrine at 1 and 100%, 1 per 100,000 parts, and with no tourniquet. This kind of vasoconstrictor, epinephrine, is a mild doses of epinephrine. We have 1 per 500,000 and 1 to 200,000. And this is a mild vasoconstrictor effect that it will be not dangerous for the two. And in the other hand, we have the control group, and the anesthesia was performed at 1.8 milliliters of mepivacaine, 2%, and in the surgery, we put the ring tourniquet because the effect of anesthesia is a vasodilator. They open the vessels, and if we don't perform a ring tourniquet, we could have a large bleeding. Well, the surgical steps of the nail procedure was in the 2 groups the same. The only difference was the anesthesia used for the block anesthesia. The first step was to remove the nail spicule excision. This is the 2 steps to take out the nail spicule. The second surgical procedure was intensive mechanical curettage, performed with a Martini instrument. We do a large removal of the nail matrix and of the nail fold. And the third surgical procedure was a strips closing in the 2 groups. As you can see in the pictures, this is a case of an experimental of a control case, because you see the ring tourniquet in the base of the 2. In the experimental group, we have no tourniquet in this base of the 2. What were the variables measured? Pre-operative, we measured the latency time, the time in which the anesthesia makes effect. And postoperative, we measured the active time, the anesthetic effect, the hours that the toe are under anesthesia effect, the feeling of pain when the anesthetic effect had worn, and after the effect of the anesthetic effect, what was the pain felt by the patient, and during the rest of the day, we have two variables of pain. Also, we measured the increase in swelling around the ponychium, and also the postoperative bleeding. The pain measurement was made by a visual analog scale in a application of mobile, in which the patient, you can see the colors, puts the feeling of their pain in this screen in green, yellow, and red colors. We measured the VAS, the visual analog scale, 2 times, and we used the mean for the statistical effect. The postoperative bandage bleeding was assessed as a visually in light bleeding, when only the first gauze was with bleed. Moderate, where a large bleeding of the gauzes were observed. Abundant, where a large bleeding was observed in all the gauzes and slightly in the external bandage, and very abundant when the all gauzes and external bandage were taken with blood. What were the results of this study? Well, this is the statistics of the latency time, active time, and pain after the anesthetic effect. We can see that we have a statistical significant difference in the latency time. We found that experimental group, the anesthetic effect was faster than in the control group. A mean of 8 minutes in the experimental group and a mean of 11 minutes in the control group. Okay, in the active time, we also found difference in the active time. Maybe is the main difference in this study, that the active time of the anesthetic was 6 hours in the experimental group and 3 hours in the control group. The effect of the vasoconstrictor with the anesthetic was longer in the experimental group, and pain after the surgical procedure was also lower in the experimental group. Patients feel less pain when the anesthetic with vasoconstrictor was applied. So anesthetic with vasoconstrictor was found to have less latency time, was more active in time, maybe the double hours of effect, and was less painful after the surgery. However, we found no significant difference between the groups in the pain per site during the rest of the day. The rest of the day, patients feel exactly the same pain after when they had worn the anesthetic effect, and also in the increase of inflammation or swelling of the toe circumference. This is logic because this increase of inflammation, this increase of swelling, was directly related with the surgical procedure, not to the anesthetic use. Also, in the results, we found that the postoperative bleeding was moderate in the experimental group. We found that 12 patients have moderate bleeding after the surgical procedure, 5 abundant, and only 1 very abundant. But in the control group, we found that only 3 patients have moderate bleeding, 11 patients have abundant bleeding, and 4 patients very abundant. This is due because when you put a ring tourniquet and you, after the surgery, remove this tourniquet, there is a reactive hyperemia. When you close the toe after the surgery and you remove the ring, there is an immediate, the body knows that there is no blood in the toe, and do a reactive hyperemia, a very large reactive hyperemia that is not present in the experimental group. So the bleeding is more abundant in the control group than in the experimental group. What is the discussion, or how can discuss our results? Our data were consistent with those of Córdoba Fernández and colleagues, who report a latency time of 3 minutes and active time of 6.5 hours in digital block anesthesia when using the phenol alcohol technique. So if you remember our results, that with 3.3 minutes of latency time and the active time, the results are very, very similar due to the same anesthetic used in our study and those of Córdoba Fernández. That was mepivacaine 2% and vasoconstrictor one part per 100,000 parts. Okay. Also, because no tourniquet because was used in the experimental group, there was less bleeding due to reactive hyperemia upon the reloss of the ischemia. In the experimental group, the hyperemia was not present because we have no ring, and then when we close with the strips, there is no more bleeding. The bleeding observed is due to the walking of the patients. The patients after the surgery go walking for their houses, for their homes, and they are relatively active in this day. So the bleeding is due to the activation of the rest of the day. Absence of postoperative vascular complications in our patients reinforce that adding vasoconstrictor is safe for patients with no vascular disease. All our patients have no vascular disease, and this means that if you have patients with no vascular disease, you can perform anesthesia with vasoconstrictor. Okay, what are the conclusions of our study? In mechanical matricectomies, the addition of epinephrine to the local anesthetic can obviate the use of a tourniquet and provides greater control of pain immediately after the intervention. This can improve the patient's perception and comfort when faced with the surgical procedure. So that means that if we have patients very sensitive with pain, we can use this kind of anesthesia. I have 2 questions that if no one has questions of this study, or maybe it could be reflections. We must use anesthesia with vasoconstrictor. We have to do with vasoconstrictor ever? The answer is no. We can use in some cases. I feel that it's better to perform the surgery with a ring tourniquet, even in phenol matricectomy, because we have a very clean surgical field, and without tourniquet and with vasoconstrictor, there is a little bleeding that makes that you don't see perfectly the field, the Nile fold. There is a little bleeding that, if you are very experimented, it will be not a problem, but in a non-experimented podiatrist could be a little bit difficult. Can we have complications? Yes, we can have complications in patients with obvious vascular disease, and or in patients with non-controlled high blood pressure, because the vasoconstrictor can alter, can modify the blood pressure in patients with non-controlled high blood pressure. So caution with this kind of patients, and anesthesia with vasoconstrictor could be a tool for the podiatrist to manage perfectly all our patients and all our problems, or we can use in some cases to do a better podiatry practice. This is all. Thank you for your attention. I have put a photo of Malaga. We are not in Malaga, but our souls are in Malaga, and hope that in the next year we can meet together in this wonderful city. Thank you very much.
Thank you, Professor Martinez-Nova. Thank you for your practical speech, and also for respect the established time. So it's time for the audience if they want to transfer any question or any comment. We have some minutes.
Okay, perfect. Thank you.
And in the meantime, I would like to know if any of your patients had granuloma. So my question is, if the surgery is more aggressive, the results are the same. Do you know what I mean? Yeah,
in this case series, we have only patients with stage 1 and 2 with no granuloma.
Mm-hmm.
If you have more severe cases, like in stage 3 with a large granuloma, with a large nail fold, maybe you don't find the same results, mainly in the bleeding, because mm-hmm. if you have to cut this granuloma, you are damaging more vessels, and maybe the postoperative effect in bleeding will not be as like in these cases, because the cut of the granuloma will provoke large bleeding, more large bleeding. Maybe in the anesthetic effect, it will be the same, but not in the bleeding. In the bleeding, and
for the pain.
Sorry, and the pain.
The pain.
The pain is directly related with the surgical procedure.
Mm-hmm.
So if you have two groups of with the same disease, you will have the same pain, I think.
Mm-hmm. I agree with you. So thank you very much.